Hello everyone, my name is Matthew Duprey. I'm a postdoctoral research associate at the Brown University School of Public Health. Today I'll be presenting on our research association between perioperative medication use and postoperative delirium and cognition in older adults undergoing elective non-cardiac surgery. I present this on behalf of our author team, which includes my dissertation committee at Northeastern, as well as a large number of researchers at the Marcus Institute for Aging Research at Hebrew Senior Life. We have received funding for this work from the National Institute on Aging, including a P01, an R24, a K24, and an F31. So we know that postoperative delirium is frequent in older adults and associated with postoperative neurocognitive disorder. Medications are a known modifiable risk factor for delirium, but studies in the past that incorporate medications often evaluate only the number of medications, not the types of medications administered. 4 studies have evaluated specific postoperative medication use. Those studies, however, are nearly 25 years old. They did find that benzodiazepines and anticholinergics were associated with an increase in postoperative delirium. Meperidine, however, was the only opioid associated with postoperative delirium, and we know that clinical practice has changed slightly since 25 years ago regarding the use of meperidine. Data regarding the association between medications and postoperative cognition controlling for delirium, in particular, are sparse. So our objective was threefold. We wanted to look at the association between pre-surgical medication use and postoperative delirium, the association between inpatient post-surgical medication use and postoperative delirium, and then look at the association between medication use and cognitive decline at 1 month, controlling for postoperative delirium. So we conducted a secondary analysis of a prospective cohort. This is the SAGES cohort, which looks at adults greater than 70 years old undergoing elective non-cardiac surgery. Patients were interviewed preoperatively in their homes to determine home medication use. Postoperatively, there was a daily collection of hospital use of 7 classes of medications. Delirium was assessed daily using the confusion assessment method, which was supplemented with validated chart review. And cognition was evaluated both at baseline in the patient's home and 1 month after surgery using a neurocognitive battery. For pre-hospital medications, we created a generalized linear model using a log link, controlling for age, gender, surgery type, Charlson Comorbidity Index, and baseline cognition. For postoperative medications, for those with a prevalence of at least 5%, we used a time-varying Cox model, controlling for all the same things as baseline and adding the Apache 2 score in. And for cognition, we used a mediation analysis, controlling for the same thing as the postoperative evaluation. Our cohort was about 77 years old, 58% female, and 7.5% non-white. The majority of our patients were in the hospital for orthopedic surgery, with a low number of comorbidities, an Apache 2 score of about 12, and a general cognitive performance, which ranges from 0 to 100 with a population mean of 50, of 58 at baseline. Looking at the association between pre-hospital medications and delirium, we found when we adjusted for all of those covariates that there was no significant association between any pre-hospital medication class and postoperative delirium. Looking at postoperative medication use, we found a large but non-statistically significant association between antipsychotics and delirium. We did find an increased risk with benzodiazepines and injectable opioids. We also found that oral opioids, when controlling for worst pain, were associated with a decrease in postoperative delirium. Looking at the mediation analysis, looking at cognition, the only significant result was for the indirect effects, so the effect of antipsychotics on cognition as mediated through delirium, and that was a decrease in cognition of 0.34 points at 1 month. The standard deviation of that score is 10. So we know that there's been advances in surgery and postoperative care that may have affected our medication and postoperative delirium association reported here. We also know our analytic power was constrained by medication prevalence. Pre-hospital medication adherence was not assessed. Our stratified opioid analysis is subject to confounding by indication. We did not have medication dose data and could not incorporate it into the analysis, and our mediation analysis is potentially subject to reverse causation bias. However, our conclusion is the administration of benzodiazepines to older adults hospitalized after major surgery is associated with increased postoperative delirium consistent with previous literature. Prescription of oral versus injectable opioids has the ability to decrease postoperative delirium in older adults. Thank you, and I invite you to ask any questions or reach out to me if you have any information you would like. Thank you.